So I have had difficulty hearing you, Professor Sufia, but I am assuming that you're inviting me to answer the first question, which is the impact of COVID on vitreoretinal services.
Yes.
Also, I think there were some sound issues, so I'd just like to take a moment to introduce myself. My name's Rahila Zakir. I'm a vitreoretinal consultant at the Western Eye Hospital, which is part of the Imperial College NHS Trust group of hospitals, and I work in Northwest London, which is a regional vitreoretinal unit. And I'm also honorary clinical senior lecturer at Imperial College London. So that's just my background. Now, in the UK, I work in the NHS and privately, and we all know that in the government system versus the private system, we have to differentiate urgent cases from elective cases. Now, what happened in COVID was that a lot of vitreoretinal units were not able to operate because their theatres were shut down, they were converted to intensive care units, their staff were redeployed. So there were about 2 units which are dedicated standalone eye hospitals in London, which was the Western Eye Hospital and the second one was Moorfields. So we were the 2 units that were really providing all of the vitreoretinal services, not just for the whole of London, but the surrounding areas. And in the first wave, which for us went from about March to June, our 6 weekly VR sessions and weekend operating were cut down to 3 morning lists shared with every other ophthalmology emergency as well. So we had very, very limited capacity. And so we could do our retinal detachments, the MAC-ons and the MAC-offs, and some trauma. Everything else was postponed. So all the elective surgery, epiretinal membranes, macular holes, diabetic vitreous hemorrhages, unless it was an only eye, fractional detachments, everything was put on hold. From around July, August, September, we started recovery and started clearing the backlog, and which we were just beginning to catch up with when we went into a second wave of lockdown from January through to April this year. So patients who'd been postponed last year were given dates for January onwards, and they got cancelled again. So our situation at the moment is that we have managed to keep up with all the emergency operations. Everyone else we have stayed in touch with. And so the other thing that was happening was outpatients. A lot of patients were converted to virtual consultations. You only saw someone in person, face-to-face in the hospital if it was necessary. So our post-operative patients came in, but our electives, we stayed in touch with them. We checked in on their symptoms by phone calls in clinic sessions. The epiretinal membranes probably haven't suffered too much. The macular holes are probably enlarged in the time that they've had to wait. And I think they're probably the group which were always intermediate. The emergencies are easy and the removal of oil or epiretinal membranes are easy. It's those intermediate cases where, yes, if you leave things from 3 months to 6 months to 1 year to 18 months, yes, the prognosis can change. So from our point of view, that's the group that we're trying to prioritize. And we categorized all our patients into priority 1, which had to be operated within 1 to 3 days. Priority 2, they had to be operated within 2 weeks. Priority 3 could wait up to 3 months. We tried to put our macular holes in there. And then priority 4 could wait longer than 4 months. So that was really how we worked on it. But we still have hundreds of patients as a backlog, and we're working through those now. Our anesthetists were redeployed as well. So having anesthetic cover for our intraocular surgery was also necessary in a standalone hospital for us. Professor Sufia, is there anything else you'd like me to add to that?
Thank you very much. That was a very detailed answer. We have understood very well how we are dealing with the backlog of all those vitreoretinal patients that have not been attended to during the COVID situation. I would like to direct my next question to Dr. Nusrat Chaudhary. Professor Nusrat is probably not, most of us don't know that, but she is an expert in retinopathy of prematurity diseases, and she is dealing with a lot of patients in Bangladesh who are in ROP patients. So, what is your experience regarding the incident, the management of ROP in Bangladesh?
Thank you very much. Greetings to everybody from Bangladesh. Thank you for your question. See, ROP situation in Bangladesh is getting actually worse because there is improvement in the perinatal services. and there is improvement in the infertility treatment. So younger and younger babies and more lower and lower birth weight babies are staying alive and they're thriving well.
Right.
So, you know, we all know that ROP comes in hand with actually development. So, you know, we have seen the historical sides of the first incidents in Europe when Europe was becoming better. There was this oxygen, and then there was the perinatal services. So the same thing here over here, because we are developing NICUs and our perinatal services has improved. So number of cases of ROP actually is increasing day by day. The service of ROP is there in Bangladesh, but it is more or less main big cities centric. So a lot of the patients from the periphery tend to come to us a bit later. So we do see complications. We still see stage 5. So that's very unfortunate. And we're trying to actually raise the awareness about ROP in our country. We have very good communication and collaboration with LDPI. Subhadra Jalali comes often, and we are trying to train people in the peripheries because the services are city-centric. You know, you need to come to a tertiary level hospital to get service for ROP, but the screening has to be in periphery wherever there is an ICU. The point is that, you know, if you have an ICU, there should be screening for the eyes. But the thing with ROP is that you need to screen it. You can't do it with that direct ophthalmoscopy. You have to be efficient. You know, you have to be good at indirect ophthalmoscope, and we need to train. Not only, it cannot be dependent on the retina specialists only or pediatric ophthalmologists only. Even you don't need doctors. For screening, if you train the head nurse, she can at least do the screening. That is where we are lagging behind, and that's why, because we have to do everything, and not all the NICs are covered. So the cases are still coming that are not that are stage 5, stage 4B, which is very unfortunate. This is something we don't want, so we are trying to create awareness. At the moment, like 30% ROP would be 30%. A lot of PP-ROP cases are also there. As I'm saying, the infertility treatments are very good now. Therefore, the quadruplets and triplets are being born. Another interesting thing I think is important to state. I've seen it in India while I was training there, and our collaboration is good with them as well. I'm sure it's the same in Pakistan as well. You know, the European criteria for screening needs to be, you know, it has to be different from, I find it is different from us, because we do see larger babies and more older babies developing ROP. That is probably because the oxygen monitoring system is not as good as European countries or American countries. So this point needs to be highlighted as well. So this point, I think, will be similar. I don't have the actual, I don't know about the Pakistani situation, but I'm sure bigger babies and more mature babies, actually, not mature babies, relatively older babies do tend to have ROP in our country. So we have set our criteria at 35 weeks below, at 35 weeks or below, and or 2,000 grams or below, and any baby who has had a stormy NICU. That's our criteria. Thank you.
Thank you so much, Professor Nuzhat, for that detailed answer. Yes, I am in full agreement with you. Basically, it is the screening of the patients that is more important, because the management is largely dependent upon that. And the more healthcare professionals we treat in screening of the retinopathy of prematurity patients, the better off we are in dealing with the patients at a later date. So thank you for the detailed answer. I will direct my next answer to Professor Rubina. Professor Rubina is also a VR surgeon who is practicing in London. We will ask a surgical question from Professor Rubina, of course. And what we will like to know is that, Professor Rubina, what do you think about the usage of chandelier light for the buckling procedures?
So thanks for this question. It's an area of my interest. About I think about 6 or 7 years ago, I introduced the use of chandelier for scleral buckling and retinal detachment surgery. We know about the use of chandelier in vitrectomy surgery for peripheral shaving and bimanual surgery. So I'm a great fan of chandelier. So I use chandelier for all my retinal detachments with vitrectomy for retinal shaving. And I know the the advantages of the wide field view with the chandelier. I started using the chandelier with the scleral buckling procedure. Now, first of all, the procedure is exactly the same as any other scleral buckling procedure, but instead of an direct ophthalmoscope, we're using the chandelier. I tend to do the scleral buckling under the microscope from the beginning because it is much more magnified view to see tissue planes and to judge the depth of your scleral sutures and lots of obviously good for the surgeon as well, because nobody will ever find out when you became presbyopic, as you will always be using the microscope. So it's been a great, one of my supervisors taught me to do it, and I wasn't presbyopic then, but I've been using it, and it's a great view. There's a little bit of getting used to, but once you get used to it, the benefits really are great. So so what I would do normally is, like in a DS type of a procedure, I'll just open the conch, sling the muscles, identify for any scleromalacia, mark the break, and well, not mark the break, sorry. At this point, I'll just put a chandelier in. So the patient will often be a young patient, because we often tend to do vitrectomy in the older patients. So it's just the young patients that we don't for these days do vitrectomy and would do scleral buckling for a chronic retinal detachment or a retinal dialysis. So often the patient is young and phakic. So we'll put the chandelier at about 4 millimeter from the limbus. I tend to use the 25 gauge chandelier. The 27 gauge is just too flimsy for this type of surgery. It can easily be, the fiber optic can easily get crushed during the movements of the eye with the scleral buckling. So, so I'll put the chandelier in, put your wide angle viewing system in, and just have a look all around. You've already slung the muscles, so you can move the eye around to wherever you want. The chandelier should ideally be placed 180 degrees away from the area of the pathology. And then once I've done that, then I would identify where I'm going to put the band, just like when we're doing scleral buckling with the indirect ophthalmoscope. I'll also find out where's the highest point of the subretinal fluid to find an area for drain. And at the same time, look for any other peripheral pathology. This is especially useful in small round retinal holes, which may be difficult to see with indirect ophthalmoscopy when doing these detachments. So after that, then I remove the chandelier, I pre-place the sutures, drain the fluid, put the gas in, put the explant in. Obviously, before that, I do the cryo as well. The cryo, I must say, is that it's very, very precise and with the chandelier view. And you just avoid excessive cryo. You avoid cryoing lesions that look a little bit suspicious, because you can get a very magnified view. So cryo is limited, which is always good, because cryo breaks down the blood retinal barrier, and it creates inflammation. So so after that, then with the air bubble in, then or I may put a gas bubble like SF6, and following that, I'll just close the eye and remove the chandelier. The patient, obviously, there can be a vitreous strand in the chandelier port sometimes, so you can always put a suture there. I tend to put a suture, although other people may leave it without any stitches. And I've done quite a number of cases. I've not had any problems, like any entry side break near the chandelier or any problems with it. I've not had any lens touch. One should try and remove the chandelier when we are doing big movements of the eye, such as when replacing the sutures and putting a buckle on. As long as we are careful, then the chandelier is, it doesn't protrude that forward to affect the lens. The other thing is that initially I was a bit tempted to inject the gas through the port, but then the gas, because the port is very big, the gas immediately came out. And so I would advise that we make another incision, we inject the gas with the needle rather than with the port, because it comes out as soon as it goes in. So I think that's briefly, my experience with the chandelier.
Well, thank you very much. That was very informative. I'm pretty sure people who are using chandelier light for other procedures would also like to use chandelier in light of your experience for scleroblocking procedures as well. Now that we are at it, can you tell me whether you're using chandelier light in routine your VR surgery as well, or do you just pick and choose your cases and use chandelier when you need to use both your hands, or in cases where like you think the visualization is not that good with just the other light, normal light?
I must say I'm a bit spoiled. So I do use the chandelier for all my detachments and diabetics. I believe that primary retinal detachment surgery is the best chance for a patient to regain vision, and therefore I do peripheral gel trimming. I tend to go very anterior to the breaks and obviously try to drain through the breaks without creating a retinotomy. And because of that, I have to have a chandelier for that as well. Also, the 360-degree laser, which are sometimes used for 4-quadrant pathology, the chandelier comes in handy. So I do combine phaco-vitrectomy for all my patients, including detachments and diabetics, and the peripheral gel trimming is only possible with the chandelier. I have done redo cases after other colleagues have operated on them, and I was surprised at the amount of vitreous that I found that was left in the vitreous cavity.
Thank you very much for that. We would just like to shift a little bit from surgical vitreoretina to a little bit of medical retina as well, so that people get an insight of both the aspects of the VR while we're at it. So I will now direct my next question to Professor Huma. Can you hear me, Professor Huma? Can you hear me? We can't hear you. Please unmute yourself.
It's unmuted now.
Okay, yes. So Professor Huma, you are a VR surgeon as well, but we also know that you're doing a lot of medical retina. So I'm going to direct my next question to you from the medical retina side. So we would like to know about your views regarding the use of steroids in various retinal disorders.
Okay.
The use of steroids.
Thank you so much. Thank you, Sophia, for inviting.
And how?
Okay. Thank you, Sophia, for inviting and for conducting such a lovely Women Ophthalmology Pakistan. This is the 4th webinar that we're holding, and we'd like to welcome all our international and national speakers. And I'll now switch fast to the question, but before that, I'd just like to add on to the question, to the answer of Professor Dr. Nuzet, that when she was talking about the retinopathy of prematurity, that screening is the ultimate key. When once you start the treatment, then it's a never-ending story, because if you're going to attempt lasers, you can prolong your the follow-ups. But if you have to use the anti-Vegfs for that, then it's not just the ocular examination that becomes a point of concern. It also becomes the pediatric evaluation. So these patients who will be given anti-Vegfs for their retinopathy of prematurity will have to be picked up by the pediatricians also, and to look at their milestones, because anti-Vegfs is known to cause delayed milestones or affect their neurological development. So anybody who's given anti-Vegfs will have to be looked into that aspect also. And the study that we're doing, if we're giving any anti-Vegfs, we have the pediatricians on board, and then we're carrying and following those patients or those children up to 2 years of age. So now coming to the one that you're talking about, because it is a part of medical retina, and I really wanted to continue with the ROP also. So now coming to the steroids. When we talk about steroids, I strongly believe that this is since last 2 years we're going through the COVID, and I think there is nobody who doesn't know the advantages of steroids. So if a steroid is a life-saving drug, it is also a vision-saving drug. I strongly believe that ophthalmology cannot work, or anterior segment and especially the posterior segment cannot work or cannot produce its results unless you have your steroid in hand. So the steroids, but which medications, what type of steroid, what patients to give, and what are the diseases in which these steroids are used are the cause of that. That is what is important. So when we talk about the posterior segment, we're talking about the vitreoretina or the medical retina, we need to categorize the main diseases in which the steroids have very, very important role. So starting from vascular problems like, leakage in the form of diabetic macular edema, which is refractive, which is not improving. And when we say that persistent macular edema or refractive macular edema, which actually talking about an edema which is not settling with any anti-Vegfs or other sort of things for more than 90 days, and every time you look, the edema still persists and is not going down. So that is the time when you think of adding on a steroid. So for a posterior segment disease, apart from the fact that it's posterior non-infectious uveitis, where steroids will be taken up as a challenge from the very beginning, the rest it will be like a combined treatment with other important treatment regimes like the anti-Vegfs or like if it is an infective element, has to be looked into it. So the steroids, whether it's like different types of steroids, whether it's in the form of injectables, whether they are ocular, whether they're periocular, whether they're systemic, all have to be kept in handy. But when we're talking about the ocular problems, it's mostly the injectables that we're concerned with, because the topicals have a problem of crossing the the anterior segment, and the amount that you need or the concentration that you need in the posterior segment is reduced. So if you have to look at the posterior segment, we can start with the systemic steroids in the form of deltacortils or prednisolones. Then you can have the topical, and then the periocular in the form of subtenon injections, subconjunctival, subtenon, and then you can go into the intravitreal regime. And now, which is the most hot topic of steroid administration, is the suprachoroidal route of administration. So all these steroids, whether they are like the dexamethasones or they are the triamcinolones and all that, their route of administration will depend on the type of retinal pathology, whether it's a vascular, whether it is inflammatory, because all steroids are known to be anti-inflammatory, and they are anti-angiogenic also, and they also help in reducing the edematous level of the retina. I hope I've been able to answer in 2.5 minutes or 3.
You can take as much time as you want. We have loads of time. We would wish our audience to understand the discussion. We're not short of time. Thank you very much for your detailed answer, Professor Huma. I will direct my next question to Dr. Tahmeena Jahangir. And from Tahmeena, what we would like to know is that the latest technology right now under use is that of intraoperative OCTs during surgery. So we would like to know about your opinion regarding that, whether you've had any experience or not, and what do you think, how useful that is to have an intraoperative, even if you have not used it, how useful do you think it might be to have an intraoperative OCT during surgery? Please unmute yourself, Tahmeena. Can you please unmute yourself? Yes.
Thank you, Professor Sophia. Yes, to be honest, I've not had the experience of intraoperative OCT. I've been going through a lot of literature and videos regarding it. So I would just like, for the benefit of the audience, to go in a bit of background about how it all started. So the initial transition from imaging in the clinic to imaging in the operating room was made by modifications in the available tabletop OCTs. One of the major breakthroughs was the development of a compact handheld OCT scan head. And that had several advantages, like it provided a tremendous level of flexibility to scan the retina, ability to dynamically alter the position of the scan. However, it has a very steep learning curve, and the reproducibility of the scan location was very difficult. To overcome these issues, the manufacturers then developed microscope-mounted systems, which provided increased stability, precision, as well as increased scan efficiency, and they had easier learning curves as well. However, true microscope integration did not develop until they had integrated OCT into the microscope. And it was a major step forward, and it provided real-time imaging of the procedure which was going on. So development of these systems allowed a 3D stereo display, which could be projected into one or both oculars of the microscope, depending on the manufacturer which is providing. And nowadays, commercial integrated systems are available from Haagstride, Leica, Zeiss. And further work is being done to enhance the image quality as well as the acquisition speed. Plus automated tracking software and advanced software analysis is also being developed. The most common indication that comes to mind when you are thinking of intraoperative OCT is peeling of membranes, as in case of a macular hole, epiretinal membrane, in case of vitreomacular traction. So in that case, it is very helpful in identifying the membranes that need additional peeling, or alternatively, it confirms the successful attainment of your surgical objective that you peeled the entire membrane. It has also been used in cases of optic disc pit to help confirm a direct connection between the vitreous cavity and the area of Scheisser's, as well as it is now increasingly being used in several centers for in RD repair to see whether or not the peripheral fluid has been absorbed. And is very helpful in cases of delivery of subretinal therapeutics. Plus, it has a very, very important role in pediatric VR surgery, where children do not cooperate easily for an OCT scan. So, when the patient is under for an EUA, the child is scanned and OCT is performed per-operatively, just to assess the degree and level of disease. That is basically what I would like to share regarding the intraoperative OCT.
Thank you, Dr. Fahmina. We have two wonderful VR surgeons here from UK as well. So have you people had any opportunity of seeing or using intraoperative OCTs during retinal surgeries in your centers? Dr. Rahila and Dr. Rabina, maybe?
So I don't have any experience in our center. In the NHS, again, we're very limited. It's mostly research-based units that have got them. And where I've seen them being used is in gene therapy for the delivery of subretinal, medication. So that's my only experience, and that's also not personal.
Thank you. Thank you for your input. I will direct my question to Dr. Farah. And Farah, we would like to know, Dr. Farah, can you hear me? Good. Please unmute yourself so that you can answer my question. We were talking about OCTs right now, and I would like to know about your opinion regarding the diagnostic accuracy of OCT over fluorescent fundus angiography and research and practice of VR diseases.
Thank you very much. It's lovely to be here. So since the advent of OCT, we all know that it has very much taken over FFAs in our clinical practice, but it has not been able to totally exclude it. Rather, they complement each other. So I think FFA is very useful in initial diagnosis of some diseases like neovascular AMD, and then in some complicated cases like the polypoidal vascular choroidopathies. However, in the monitoring of the disease, I think the OCT has really taken over FFA. So if we talk in terms of research, usually that has been done in the aspect of neovascular AMD, and there has been found a correlation of about 80 to 85% between the findings of FFA and OCT in these cases. So I think, however, in all other cases, like the diagnosis of diabetic retinopathy, the management of diabetic retinopathy, AMD, the chronic macular edema, the CSRs, and then VMT or epiretinal membranes, or in the cases of macular hole, we are very much dependent on OCT for the diagnosis, then the staging, and then the monitoring of the disease. Also, the difference being that OCT is very handy and easy to carry on, and it's like a non-invasive technique, so that very much helps us. And then the medical history of the patient is also not relevant much in cases of doing an OCT as compared to FFA. So I think yes, FFA has been, its role has been taken over by OCT in a lot of cases. However, we cannot rely on totally rely on OCT over FFA.
Thank you, Dr. Farah, for your detailed answer. Since we are talking about OCTs, I thought I'll take my next question to Dr. Rubina. And we will ask her about the OCT features of the various subretinal vitreous substitutes in patients who present after vitrectomies, in post-vitrectomy patients. Dr. Rubina, please unmute yourself, please.
Yes, thanks. By subretinal vitreous substitute, I believe we mean perfluorocarbon liquids. And these are intraoperative tools that we use during VR surgery. And they are toxic to the retina, so they should really be removed completely before the end of the procedure. Sometimes they can slip into the subretinal space. This often occurs in cases of retinal detachment or especially those with proliferative vitreoretinopathy or redo detachments who require retinectomy. So whenever a large area of the subretinal space is exposed, the PFCL, which get emulsified during the introduction of instruments, a smaller bubble can obviously go into the subretinal space. It also occurs if there is traction on the retina, which is not resolved. If we have peeled membranes, like say in a funnel retinal detachment, but there is still residual traction on the posterior pole, then when we start injecting the PFCL to start flattening the retina posteriorly, and if there is a break, then it's an ideal situation for the PFCL bubble to go under the retina. And also with a smaller gauge vitrectomy, it's believed that the incidence of emulsification may have increased. So as far as the OCT picture is concerned, clinically we can see that on fundus examination, the PFCL is a well-defined bubble, which is, you can see the margins, and it's in the subretinal space because you can see the blood vessel traveling over it. It can be found anywhere, usually in the posterior pole, where it's of concern to the surgeon. It can be in the peripapillary area, in the macular area, or in the subfoveal space. I think it just gravitates to these parts of the eye. So it looks like a well-defined droplet in the subretinal space on OCT examination. So the OCT can help us in deciding how to manage it. Basically, if it's extramacular, then the chances of it migrating to the fovea are small. However, it can occur. If it's extramacular, and now these patients often will have silicone oil in the eye, because these are complex patients. So if we've used PFCL, we would have always used silicone oil as well. So it's not that easy to just go and remove the PFCL, and it should be used as a last resort. Often the prognosis may also be not so good in these patients. So we have to prioritize whether it's the central vision that's more important or the retinal peripheral retina. So as I said, if it's extrafoveal, then it can be left and watched. If it's subfoveal, then it causes more concern. Sometimes the PFCL may be there and may not have been seen on the first few postoperative visits, and it may be just when you do an OCT it is discovered. At that point, it is possible that there may be a bit of a capsule formed around the PFCL droplet or pigmentation, and this can be seen both clinically as well as on OCT examination. Then this should tell us that we should not attempt to remove this PFCL because there is a capsule around it, and that it is not going to come out easily. Anyway, if we embark on removing the PFCL, then it will have to be combined with the removal of silicone oil. So firstly, the silicone oil will be removed. Then we will just puncture directly over the PFCL bubble and aspirate it. Obviously, it's not a very good way of doing it, but compared to other techniques that have been suggested, which involves redetaching the retina and then getting the PFCL out, which can result in folds in the retina and various problems in these high risk eyes. Probably just directly puncturing over the PFCL is probably the best solution, and then putting a bubble of gas afterwards. So I think that's you know, that's the gist of how you know, how PFCL can behave. Other than that, I'm not aware of any other. I don't know if any of the other VR surgeons can add if there is any other vitreous substitute that can, you know, subretinally migrate, and if you have any experience of those, CT.
I think the most common substitute that everyone comes across is PFCL, and thank you very much for describing in great detail not only the OCT findings, but the surgical practical management tips as well. So while we are on OCT, I will direct my next question regarding OCT to Professor Nosrat, and we would like to know about your opinion regarding the role of OCTs in the various retinal diseases. Professor Nosrat?
I believe Farah has a bit of touched on that. See,
Yes.
OCT, OCT, you know, it's a volumetric scan. You can see the retinal microstructure. It's like, you know, it's like live biopsy, which was not possible before. So OCT really is a very helpful modality of investigation. And rightly, Farah said that since it has come into our practice, it has taken over so much of our diagnostic areas, because it's so easy to do, it's so convenient, and it's non-invasive. So there are so many advantages of OCT. And for, you know, you need to see, when you need to diagnose something early on or follow up, you need to see the structure. And OCT gives you such good layer by layer volumetric scan of the microstructure of retina. So, you know, any intraretinal fluid, any traction, VMT, vitromacular traction, or any diseases of, it could be sub-RPE, it could be a macular hole. You know, you can see them all in ARMD, atrophy, and atrophy of geographic atrophy, and, you know, so many other things. Particularly, OCT is so good when you are trying to see the macular edema. You know, we have to give it, we all are very aware of the frustrating journey that we all have to take of repeated injections for the macular edema. So, you know, every time you need to monitor, and you need to have a close eye, and you can't do it with an invasive procedure. So the fact that OCT is a non-invasive procedure and so easy to do, it doesn't hurt, it doesn't take much time, it's a matter of seconds actually. So, you know, it is a very useful thing to see all the layers, not only of retina, choroid, and vitreous as well. So vitromacular traction I can see, and, you know, macular hole, lamellar macular hole, some things that even you can miss clinically you might find in OCT, like just we have heard from Rubina about the subretinal subfoveal or extrafoveal PFCL that may not be very visible to you on the first few postoperative days, and it's only after OCT that you get it. So, you know, OCT is very important, and not only for the early diagnosis, not only for the diagnosis of a disease, but also for the follow-ups as well. So we have been using OCT for not only macular edema or CNVM, we have been using OCT is part and parcel of our everyday clinical practice. Thank you.
Thank you so much.
I hope I've done it in 2 minutes.
As I said, and I'll repeat, we have loads of time. You don't really. Thank you so much. I will direct my next question to Dr. Rahila. We have kept you waiting for a very long time, haven't you? So we would like to hear your opinion about the utilization of suprachoroidal space, because nowadays the people are propagating the usage of suprachoroidal space a lot. And I'd like to have your view around that.
So I think the suprachoroidal space is something that we've all known exists because we've seen it in cases of suprachoroidal effusion and following particularly trauma or iatrogenic surgical injury with suprachoroidal hemorrhages. And you know, we haven't really utilized it until relatively recently therapeutically. So I think now with the OCT advances, enhanced depth, and swept source OCTs, we can actually see this hyporeflective line just behind the choroid that is thought to be this potential space, and that is what we're utilizing to deposit things in. So the main two things that I'll talk about is the administration of drugs, and particularly in relation to VR. The one that I would talk about is TPA, for the dissolution or dissolving, thrombolizing suprachoroidal hemorrhage. Now, traditionally, we have waited 10 to 14 days following a bleed for the blood to naturally liquefy before we can remove it. Now, in an only eye, this is a problem, but also in an eye that has got breakthrough bleed with vitreous hemorrhage and retinal detachment, we want to go in and clear that blood in the presence of a retinal detachment sooner rather than later, and we may want to drain that choroidal hemorrhage at the same time. And these are probably a good set of cases to start with because there is already distance between the vascular elements of the choroid and the retina and the scleral space. And the technique there, you need to give time for the TPA to actually dissolve the clot. And there are two ways. You can either put them on a list, inject the TPA, leave them 24 to 48 hours, and then bring them back to theatre to drain and do the rest of the surgery. Or you can put them on at the beginning of the list, inject your TPA, and then bring the patient back at the end of the list and drain it. So that's a relatively less risky way of starting your experience with suprachoroidal space techniques. The other technique is using the suprachoroidal space to inject a viscoelastic agent, hyaluronic acid, to create an indent, not of the sclera, but of the choroid, to enable you to tamponade a retinal break like you would for scleral buckling. Now, I don't know about the rest of the world, but certainly in the UK, our fellows' experience with scleral buckling is getting less and less because every retinal detachment that already has a posterior vitreous detachment associated with it now undergoes a vitrectomy. So scleral buckles are only kept for round hole detachments where there's no PVD and with dialysis detachments where there's no PVD. And those are few and far between in most cases. The advent of pneumatic retinopexy has also meant that actually many round hole detachments can also be approached with the pneumatic retinopexy in the first instance, as further reducing the experience of cryobuckle. So this is a technique where initially the hyaluronic acid substances that we're already familiar with in ophthalmology, such as Helon, Helon 5, Helon GV, these ones have been injected, and they will last in the eye for a few days. But there is a well-established precedent for hyaluronic acid that is designed for human use in tissue in the form of dermal fillers, which are used in aesthetics. And these are cross-linked and they can be of a range of molecular sizes, and the large molecular weight hyaluronic acids, which are cross-linked, will be more stable and can remain present without the hyaluronidase effect of breaking them down, actually for many, many months. So those fillers, although I don't know of any of that have been used for buckling, choroidal buckling at the moment, technically could be used for a longer buckling effect. So talking about using the suprachoroidal space and hyaluronic acid for anterior breaks in the traditional cryobuccal surgery, we can also talk about the more challenging cases where we've got macular traction conditions, where there is a staphyloma. And often we have talked about, although I have no experience of doing it myself, the endoplom or macular buckling, which is technically quite challenging and very fiddly. And in the, in the limitations of our NHS practice, where we've got high volumes and limited theatre time, to clear a whole operating list to do an endoplom really becomes very, very challenging. And therefore a technique with these illuminated olive-tipped blunt cannulae, where you can inject and gently progress these into the macular posterior space very, very carefully with internal visualization using a chandelier. Often this technique will be combined with a vitrectomy, where you will relieve internal inner retinal traction by doing an ILM peel and vitrectomy as well. And then there is good evidence, and this is not a technique that I've used myself yet, that there is evidence of that tamponade effect working for up to 2 years. So I think this is somewhere where those rare cases, especially in redo techniques where the first approach hasn't worked, will be something that is worth attempting. The concern in the suprachoroidal space is always massive hemorrhage, and there are literature reports, or especially in the early stages where there's a learning curve, of severe hemorrhages, either suprachoroidal or suprachoroidal and subretinal or subretinal and intravitreal hemorrhages. So this is something that needs to be kept in mind. But it's certainly, from a surgical perspective, a very, very exciting space. Some of the papers will talk about these techniques as not suitable for the office. Now, American practice tends to be very office-based, so their papers will be geared a little bit more towards techniques that can be used in the office. And so they will talk about developing suprachoroidal injection needles, which are very, very short and very fine gauge. I think a 0.7 millimeter or 1 millimeter needle actually was just about barely going to get through the sclera. So probably not that much of a guarantee of being in the same space, in the correct space. So my personal opinion is that these should be theatre-based. These should be careful dissection, blunt dissection, and you inject anterograde with the hyaluronic acid to dissect a natural plane, like you visco dissect sometimes in the anterior segment with Helon. And that creates a channel and protected space for you to advance your instruments and reduce the risk of getting hemorrhages.
Thank you so much, Dr. Rahila, not only for the utilization of the suprachoroidal space, but also giving us clues as to how to proceed about it. Yes, you're absolutely right. With the advent of new sharp needles, people are going for suprachoroidal injections a lot. And my next question to Professor Huma would be the same. So, Professor Huma, intravitreal or suprachoroidal steroids? Your take on that?
Okay. Like I said, steroids are usually not the first line of treatment in many of the posterior segment disorders, and it is usually kept in handy when needed. So whatever your treatment, except for the posterior non-infectious uveitis, where you might use it as your first line of treatment, steroids are kept as a combination drug. So if there is like the refractive edema, like whether it's a diabetic macular edema, or due to another reason, let's say maybe viscointravenous occlusions and all that, if you're going to inject steroids, I am not a very great fan of intravitreal injections, because in our part of the world, the intravitreal injections that we have is preservative, filled with preservatives. So using a preservative in the intravitreal zone is a cause of concern, because the thing that we use intravitreal in Pakistan or in the eastern side is triamcinolone, and triamcinolone is the particles, if it is preservative, if with the preservative, are not uniform. So the difference between the triamcinolone that is preservative free and with the preservative is the uniformity of the particles also. So when you're injecting, and if you're going to do intravitreal, the cause of worry is that who's actually injecting also. Is it like somebody who is trained enough to do it, or is somebody, your fellows, who are doing it? Because Injecting intravitreal, you also need to look at the site of injection, because these heavy molecular weight particles will settle down inferiorly. And it also then, and looking at also the consistency of the vitreous, if they settle down inferiorly and the distribution of this preservative-full triamcinolone is not as uniform as that of the non-preservative one. And then if it is injected superiorly, though it will cause resolution, it will help in resolution of the inflammation and the leakage that is taking place in the retinal surfaces. But it can also, the milky appearance of the steroid is going to reduce vision for a time being. And apart from that, it is also threatened in the form of, posterior subcapsular cataracts and rise in intraocular pressure, which usually seen with triamcinolone is more than about 10 millimeter mercury. And then, it keeps on going for even 2 to 3 months. So you have to put them anti-glaucoma medications also. And sometimes when you're injecting, like I still say, if we do not know whether who's injecting, if it's a fellow injecting, I have seen people having a lens touch. So you have to know where you're injecting, how you're injecting, and what you're injecting. So preservative-free, if has to be injected, should be a preservative-free intravitreal injection of triamcinolone. And then in the West, we have, even not just in the West, it can go from here to, I think Dr. Nusrat can add to it, whether they have the implants, the steroid implants in the form of, the fluocinolone or dexamethasone implants. If they're there, they're also injected. But still, all the side effects are the same. Now coming to the other route, intravitreal or posterior subtenon or suprachoroidal. When I was as a fellow, or even now, if I have to combine and get a resolution of the edema, which is we're mostly looking at the macular edema, it's like a combination. And if I'm giving an anti-Vegf, I would like to start with the posterior subtenon. Maybe I'm sure many will not agree with that, but rather than going intravitreal, to be on the safe side, looking at the consistency, and even looking that we have the steroids, which is with the preservative, I would like to be on the safer side and inject posterior subtenon along with the the combination in the form of intravitreal anti-Vegf or whatever is into the space. Now the third is that with the coming of the suprachoroidals, this is kind of a safe space, and just like Rahila said, that because of the availability of the swept source and other kind of OCTs, which are highly, they can bring up to 1 microns of space. That's when actually the suprachoroidal space was actually identified. And this suprachoroidal space is not seen normally in young adults. It is usually seen in the in the middle age. This becomes obvious. Before that, it's not. So and then if people who have this pathological retinal diseases, the suprachoroidal becomes more obvious and becomes a good route of administration. So if somebody if asking me now if I would like to inject, I still am very cautious and very hesitant in using an intravitreal injection of either triamcinolone, whether it's preservative or preservative free, and even on the implants, because some are degradable, like dexamethasone, and some are non-degradable. So the non-degradable, I have seen actually where there was once a vitrectomy was being done, and there were 5 non-degradable tiny implants found strolling about in the vitreous, and that really we were actually counting it out, the 1, 2, 3, 4, 5. So these the fluocinolones, this pellets stay for a very long time. So then you have to look whether there is a cataract there, or whether there's a phakic eyes, or whether pseudophakic eyes. Pseudophakic eyes are still comparatively safer as compared to phakic eye, because phakic eye, these implants, if there is PVD or if there's syncytic vitreous, can float around and it can even come into the visual excess. So looking at the consistency of the vitreous, looking at the type of implant, looking at the the preservative or non-preservative, I would hesitate to go into the vitreous cavity and use another route, which I think for me, because I've started using the suprachoroidal route now. So initially it used to be posterior subtenon, but now if it is, I would opt for a suprachoroidal route for administration of triamcinolone if need be.
Thank you, Professor Huma. I think you have also answered one of the audience questions, which was the role of posterior subtenon Ganacort and intravitreal triamcinolone in recalcitrant diabetic macular edema in pseudophakic eyes. I think part of your answer right now also included an answer to that. Professor, would you like to add anything else to this regarding the audience question?
I think they added the word refractory in their question, and they focused on the diabetic macular edema rather than a generalized form. Okay, for refractive, I can also say that when we say refractive or we say persistent macular edema, like I said initially, when we say an edema which is not settling, it's like you giving medications, whatever the route you're opting for, and the macular edema is not settling even after 3 or 4 months, you're doing a serial OCTs and the macular edema persists where it is. And that is when we call it as a refractive. So when we call it a refractive macular edema, then like I said, initially, if it's a fellow who's asking me this question, so I would say that try to stay on a safer route and work on the posterior subtenon, because that also gives results. It's not that it doesn't. Yeah, it might not give you as much as it is needed, but it gives you good results along with the if you're using anti-Vegfs or something to reduce the amount of inflammation, retinal pathology. And if not, like I said, for a refractive, you can try the suprachoroidal routes, because suprachoroidal routes is giving good results in case of refractive diabetic macular edema in combination with anti-VEGFs. And we're having different studies like Hulk studies going on, and these are mixing up the triamcinolone with even anti-VEGFs like aflibercept. So aflibercept in the form of intravitreal injection along with the suprachoroidal sustained release triamcinolone is being used, and the results are coming up in the form of a Hulk study. And I think the combination is moving towards the suprachoroidals now. Unmute karen, Sophia.
Thank you. Yeah, thank you, Professor Huma. I would. You referred to Professor Nusrat during your answer. So, Dr. Nazar, would you like to add something to this?
I agree with Dr. Huma. There are concerns about intravitreal injection, but I do find myself in my private practice using a lot of the intravitreal injections. I have to because of the macular edema. And in certain cases, PST in combination with intravitreal really provides very good results. I also find it that Ozurdex in some of the cases do provide very good results. So there is a bit of difference of opinion between us, but we do switch to different, especially in recalcitrant cases. You do have to switch and sometimes combine in certain cases. So that's my approach. Thank you.
Thank you so much. Thank you. Thank you for adding to this. I will direct my next question to Dr. Tahmina. Tahmina, are you in on this? So you just unmute yourself. And we are going to quiz you once again on OCT. A lot of people are disturbed about what is OCT noise, what do you do about it? How can you overcome it? So we like your take on OCT noise, what to do,
Sure.
what is it, what it is. First, you will tell us what it is, and then we will move on.
I will. So thank you, Professor Sophia. As we all know, OCT, it generates cross-sectional images of ocular biological tissues. And those images are in micron resolution. And speckle noise is basically caused by multiple forward and backward scattering of light waves, and is the primary degrading factor in OCT images. It obscures the subtle but important morphological details which can be very detrimental to clinical diagnosis. And it also affects the performance of the automatic analysis methods which are needed for objective and accurate quantification. So although the image resolution, speed and depth has been increased over the last approximately 2 decades, but speckle noise is an intrinsic problem which has not been well solved and has not been addressed properly. The most common despeckling, basically noise is what produces the granulated image on the OCT. So the most common despeckling approach that has been used is called averaging. Averaging is basically that you take several images at the same point, and then the machine acquires an average of those images to produce the best possible resolution. However, this is not a very practical approach because it takes a very long time to obtain multiple images of the same position, especially when you're doing 3D imaging and raster imaging. So a number of image processing algorithms have been developed, which are used for OCT denoising. Now, their names are daunting to me as well. They are like a partial differential equation, block matching based methods, and dictionary learning, statistical model based. All these approaches are basically have been developed using deep learning techniques. Deep learning is basically, it's a type of artificial intelligence, and it's a subfield of machine learning where algorithms inspired by the structure and function of the human brain are used to denoise the image. So although the main aim is to reduce the grainy appearance of OCT, but another important issue is preservation of image details. Because see, these image details and the margins and boundaries are what are used to for the automatic analysis. So as the noise level is high in an OCT scan, many filters tend to over smooth the image. And when they do that, that results in reduced contrast at the edges. So this is basically a thing which is a lot of work is going on this. And another important method which has been developed is based on conditional generative adversarial network, which is again, it is based on artificial intelligence, and it is used, the network is able to learn the underlying clean structure of the retina and is able to generate that. There are several manufacturers which have actually developed their own denoising software, such as Nidec has developed a very effective technique to perform denoising in their images. So that is my take on OCT noise. If there's anything else you would like me to add.
Thank you. That was good. Finally, I've come to know what OCT noise is and what we can do about it. That was nice. Farah, we will stick to OCTs and we will move on to OCT angiograms. So start talking about OCT angiographies.
So the OCT angiography is very much useful in clinical practice when we don't have the facility, or the photographer is not around for doing an FFA, or the patient is not medically fit for doing an FFA, and we want to have a quick know how about the vascularization, or the status of the macula, that whether there is any ischemic maculopathy that is going on or not. Apart from that, I think the best indications are of OCTA are mainly for posterior pole pathologies, where we need a highly detailed, depth resolved cross-sectional representation of the individual capillary plexuses, and we need to know the quantitative as well as the qualitative assessment of the perfusion of the superficial, middle, and deep capillary plexus, and especially when it is obscured by leakage, and it is very difficult to tell on FFA that what is actually the status of ischemia at macula, at fovea. So that means that it is very useful for diseases like diabetic retinopathy, retinal vein occlusions, arterial occlusions, then sickle cell retinopathy, acute macular neuroretinopathy, and paracentral acute middle maculopathy, then also AMD, where we need to know that whether it is a neovascular or a fibrovascular type of membrane, or is it a PED with serous or fibrovascular PED, the new vessels.
Thank you so much. Thank you, Farah. I was going to ask Dr. Nusrat about further about OCTs, but she has taken a Maghrib break, as Bangladesh is an hour ahead of us in time. So we will reserve that question for her when she joins us back. And I'll direct my next question on vitreoretinal surgery. We're back to surgery with Dr. Rubina talking about surgical management of proliferative diabetic retinopathy with 27-gauge vitrectomy. And Rahila, just in case that you are thinking of anything else, we'll be moving on to you after this with the same question. So this is 27-gauge vitrectomy for proliferative diabetic retinopathy. First Rubina and then Ms. Dr. Rahila.
Yes, thank you. I adapted to 27 gauge vitrectomy in 2006, and after overcoming the usual difficulties with the delicate instruments and the bending, I'm quite comfortable with it now, and I have realized that it has many benefits, especially in complex cases. Although initially when it was introduced, people thought we would limit 27 gauge vitrectomy to just macular surgery and do just the regular peels and simple cases. But the real benefits of 27 gauge vitrectomy is in the complex cases. And that's what I would like to highlight with the surgical management of proliferative diabetic retinopathy. Even in the UK, those days are gone when we used to not get a lot of PDR. Most of our patients have tractional retinal detachment, combined tractional retinal detachments, and and therefore, but anyway, I believe that any diabetic retinopathy is a complex vitrectomy, and because of the relationships of the vitreous and the previous laser and the incompleteness of the vitreous attachments, there's just so many challenges in proliferative diabetic retinopathy vitrectomy. So coming back to 27 gauge, the small opening of the 27 gauge vitrector and the high cut rate, which is 7,500 normally, but now we have the 10,000 cutter as well, with the slight beveled tip, which allows even more closeness to the retinal surface. And there is the more controlled aspiration rate, and that can be used to remove in the shave mode any adherent fibrovascular tissue from ischemic diabetic retina, so reducing the need for any scissors. So the 27 gauge vitrector is used as a single instrument with multiple functions in PDR vitrectomy. It avoids instrument exchange. It saves time, keeps the pressure maintained because there is no exchange, although that is also helped by the valved ports. And also it makes it more enjoyable for the surgeon because you are not constantly changing instruments. You are just enjoying what you're doing with just one instrument, just changing the functions of the instrument, using it as an aspirator, using it as a cutter, as a dissector, delaminator, even flushing the blood from the surface of the retina, which we used to use with the back flush. So there is, so you're just basically absorbed in your operation and not thinking, oh, I have to come out again, take the biome out and put the scissors in, and then, you know, all those things. So so the bimanual technique is I think is the best technique, where the TRDs are a bit more extensive, and this is best done with a self-retaining chandelier illumination. So I use the 27 gauge vitrector to act like scissors. Like instead of, I have not used scissors for diabetic vitrectomy for a very long time. You can use the vitrector just without doing anything to create a space between the fibrovascular tissue and the retina, and then just pushing the tissue with your vitrector and using tissue recoil to allow dissection and very little aspiration, as we know that aspiration is not good in these cases because obviously you can aspirate the retina, you can cause a bleed. So it's just to lift the fibrovascular tissue and create spaces. And then once you've created that space, then normally with scissors, you would carry on and the sheets will get bigger and bigger, and you're trying to, you know, it's putting traction on the retina as you're going more into that space. With the 27 gauge vitrector, you can do back shaving. So you put the cutter, the cutting port up and make a cut in between two areas of fibrovascular adhesions. So once you've created the space, I hope I'm making this clear because this is something that can be better demonstrated with the help of a video presentation. So once you've created these inroads into broad areas of fibrovascular tissue, then you can individually tackle these areas. So again, just creating space and on the shave mode, obviously, and obviously just removing this fibrovascular tissue as we go along. You can do segmentation for the more pointed fibrovascular tissues. I mean, obviously breaks can form, and breaks is a way of life with these complex vitrectomies, but definitely the number of breaks and the size of the breaks is very much reduced. So as I said, like I'm at the moment using the 27 gauge multifunction to lift, divide, aspirate, and cut, and I'm loving and looking forward to doing proliferative PDR vitrectomies.
Well, I'm so glad to know that there's someone who's looking forward to doing proliferative vitrectomies. It's a tedious job, isn't it? So, Dr. Rahila, next to you, your take on 27 gauge vitrectomy.
So I also love proliferative tractional retinal detachments. They are one of the most satisfying surgeries. However, my experience with 27 gauge has not been the same, and I haven't overcome my learning curve, so I move away from it because I find that even in a patient with general anesthesia, there seems to be some sort of fulcrum effect with the instruments. And when I've tried to do an epiretinal membrane or ILM peel, I find that it sort of never grips where I want it to. I believe very much in delamination compared to segmentation for diabetic tractional detachments. I believe that leaving small bits of fibrous tissue on the vascular pegs is what stops those vascular pegs from retracting and getting good hemostasis. So I think when we leave little fibrovascular nubbins, I think we increase the chance of getting post-operative recurrent vitreous hemorrhages in these patients. So I trained on 20 gauge vitrectomy, and I love those 20 gauge 90-degree right-angled delamination scissors because they would multifunction in dissecting the plane as well as just cleaning those pegs very, very nicely. We have transitioned from 23 gauge now to 25 gauge. And 25 gauge, the curve of the scissors is not as good, so I tend to need to use bimanual a little bit more to help lift up the flaps so that I can visualize my pegs, but still the technique is in my hands still works very well. I understand what Rubina was saying about you know, the sheet and the flap gets bigger and bigger and you can cause tears. It's very important not to just be aware of what's happening where you're dissecting, but the traction that you're applying that may pull on retinal adhesions and attachments elsewhere. So it's important to then change back to your cutter and keep trimming and shaving so that you're just working on the pegs and the peeling. And what happens is that you peel large areas and sheets of posterior hyaloid until you reach a peg, and then you cut, and then you can peel a little bit more. So you can have a relatively rapid delamination in that sense. So, you know, I'm going to have to try 27 gauge. The people who do it say, yes, there's a learning curve. I've just lost my nerve every time because I don't like creating breaks. And the issue with PVR detachments and diabetic delaminations is what I was taught was it's better to have holes and no membrane than to have membrane and no holes. So your goal, especially in tractional detachments, is to remove the membrane. If you leave behind membrane and you've got a hole, that's your worst scenario because that fibrotic traction will stop that hole from closing and you're just not going to succeed. So Rubina, I will come back to you for some tips and I will try 27 gauge, but I think at the moment I'm very much a scissors girl.
Well, thank you very much for your personal experience regarding 27 gauge. Most of the times people just try to make out 27 gauge as a very glorified kind of a procedure, even though they're not using it. And thank you for letting us know that there are several complications. And if you are comfortable with the procedure, as Dr. Rubina pointed out, then nothing better than that. But if you're not, there is no harm in continuing with the more time-tested procedures rather than moving on to another one. And as you said, ending up with more holes and less of the membrane. So thank you very much. Professor Nusrat, you're back after your break for prayers. And well, to your better luck, people have now come to decide that they are going to ask you regarding retinopathy of prematurity. And so we have our audience question regarding that. And I'm going to put that audience question to you. And the question is, number one, how do you differentiate between ischemic retina and avascular retina in retinopathy of prematurity? And do you go for lasers in avascular retina of premature infants if there is no retinopathy of prematurity after repeated examinations? Have you got that, or should I repeat? Okay.
No, I got that. See, in my approach is that in case of a child who has, except for extreme periphery vascular zone, I don't tend to keep a vascular retina in a child. And I personally, I don't give GA, so I don't do the large, after 3 months, you know, it's very hard to do LIO in a child who's crying and moving. So I tend to usually, you know, in APROP, you have to go for injection anti-Vegf. I agree with Huma, what she was saying, that we have to be very careful about which child and whether we will use the anti-Vegf at all, because we don't know the systemic implications, long-term implications. These babies have multiple other problems, neurological problems, many a times other vascular problems as well. So we have to be very careful with that as well. But sometimes you just have to, when there's plus sign that the pupil is very rigid, pupil is not dilating, so you have to give anti-Vegf. After that, in case of like those aggressive cases, but be very careful never to give anti-Vegf in cases that have fractional elements. So you have to be very careful about those that have fractional element. You will not use the anti-Vegfs. Now, after that, either in case of those that I've already given anti-Vegf or those ROPs that are progressing, or I have to do laser, that is clear-cut case. But those that have resolved spontaneously, what do I do then? They usually become mature. But there are actually, in reality, whoever has asked me that question, he or she is very much correct. There are some babies that do not just have mature retina. They keep on having the avascular retina. So if it is an ROP case and it has progressed and then stopped at a point, I will not leave that avascular retina behind. I don't have facilities for FFA in a child, but if you could do it, then it would be very, I have heard and seen in LVPI that they do it in cases where they cannot be sure about the extent of that ischemic zone. But I do not actually, as a rule, leave ischemic zone behind, because you don't know what are the complications that might arise in the long run. So yes, I do tend to laser any ischemic retina that I find is not improving naturally, or has the growth has stopped, and I am sure that it's not going to get any better. Then I do it by usually 3 months, because I don't give GA to these children. I don't go through that route. GA is okay if you are careful enough, but I usually tend to do laser to the ischemic retina.
Thank you, Professor Nusrat. We have taken good use of, made good use of your experience regarding retinopathy of prematurity. I will direct my next question to Professor Huma. Yes, please. Yes, Dr. Rahila. Would you like to add something?
I was just going to say that actually, although we can't tell the difference between ischemic and, you know, the avascular retinas, it's still going to have an ischemic drive. I think when the child has reached a level of maturity and has peripheral avascular retina, but has not developed ROP, there is this concept of autoablation, where it just sort of ablates itself, and therefore there is no ischemic drive. So in the UK, certainly, if they've not developed ROP, but we can see that they've got peripheral avascular retina that never vascularized, we tend not to treat. And we see some of these babies, you know, one of the differentials when you see someone as an adult with a peripheral avascular retina and a very clear demarcation zone is, you know, is it FEVR, or you ask them were they premature, and you can see that, you know, generally not much has happened in terms of developing late ROP or vascularization at that zone. So I think just again, in Bangladesh, your population is completely different. So I wouldn't extrapolate our experience to them.
No, I agree with you. I was just talking about those ROP cases that have not reached the full maturation. But for those cases that have not developed ROP, we will not do any research.
Okay. I thought that was the question was asking. If there's no ROP, would we treat the avascular retina?
If there is no ROP, there is no question of laser.
Well, thank you to both the professors. Thank you both the professors for such a comprehensive answer to the question. Professor Verma, we'll be moving back from ROP to adult retinal disorders. And the quintessential questions: what is the role of anti-Vegfs in retinal disorders? How do you use them? When do you use them? And which ones are you preferring?
I think this is a question that I think the first year fellow needs to answer this, because this is something that answering this question makes me feel very like, you know, like a first year fellow again. So we always ask what kind of, you know, the anti-Vegfs is available. We have the bevacizumab.
Professor Verma, sorry for interrupting you. This is not a first year fellow question. This is your experience regarding.
I'm not saying I'm not saying this is a first year fellow question. I'm saying that, you know, I think all of us has answered it so many times, and we asked from my residents also. So it makes, you know, makes me go back to the level of first year residents to actually answer it. So I think that's what I'm trying to say. So we always start with the type of anti-Vegfs we have. And when I was a fellow, I think afterwards, that was later on that realized that, you know, something new has come up in the form of anti-Vegfs and anti-vascular endothelial growth factors, and we would learn about the sizes and would say that the smaller the size, the better results. And then there came a change with the aflibercept appearance and all that. So we have the bevacizumab and we have the ranibizumab, and then we have aflibercept, and now that we have Bievo also, which is the brolucizumab. So looking at all of them, I think asking which one is used for which kind of retinal pathology, I think the most important thing is we always talk about the finances, the availability, and the compliance. I think and the severity of the disease. So what is the baseline visual acuity that you're looking at, what is the age of the patient that you're dealing with, and how many doses that you can inject, where your patient will be available for the follow-ups. And I think all these things are very important in selecting the type of anti-VEGF that you will be injecting. But above all, the most important is the finances. In this part of the world, it's not just in this part of the world, I have seen in the Western world also, I've actually seen very, very advanced tertiary or teaching hospitals actually with insurance covered. I've seen them, you know, having a proper discussion. The insurance people are calling the consultants and asking why, you know, this kind of anti-VEGFs been selected for this, because, you know, there's a huge difference in the cost between one kind and another. So coming back to it, I think looking at if the patient is a healthy patient and if does not have any, you know, a very major heart problems or, you know, have any neurological problems, then I think it's always good to start with the basic ones, something that is affordable. So in here we start with the bevacizumabs and we see that, you know, how the results are, how to go about it then. And then, like it said, you always start with the first 3 doses, and then you check with the OCTs to see whether there's a functional anatomical improvement or there is a functional improvement, because even till now there is no correlation between the anatomical and the functional. Sometimes your, you know, your anatomical edemas and all that are improving, your neovascularizations are regressing, and your functional improvement is not as much, and it can be vice versa also. So when usually or I think all of the world, and putting in this part of the world, we start with the bevacizumab. And if the patient is affording, and if you're looking at the cost is not a problem, then I think it's always good to go with a smaller size molecular weight, and then the ranibizumab comes along, because it has got lots of, let's say in the diabetic retinopathy DRCR next studies, I think majority of them is based on the ranibizumab, and now aflibercept is also coming along and matching the studies, and the guidelines are matching along with it. So all three have their own uses, just like aflibercept started with the wet AMD, and now then it went on to the diabetic macular edema and in the retinal vein occlusions. So all three are good. All three have their own limitations also, looking at the cost, looking at the finances. Yes, and then you have to select what kind of regime you are going to use with this anti-VEGF that you've selected. If you've selected the basic one, you have to see, then how are you going to do it? Is it going to be pro retinata, or are you going to have treat and extend, or are you going to do on a monthly basis? All this will depend on your patient and the doctor's relationship, and how how easily the patient is available for it. If the patient cannot come on a regular visit, then and is affording, then you can switch from one to the one that is suitable, like aflibercept. First 3 injections are mandatory in almost all of them, but then afterwards you can extend the the months that you have to give an injection. So all these things also matter, and I think that is the reason why, because of this compliance issue and because of these follow-ups and the traveling, and I think it's everywhere. Once you go to a doctor, once you go to a ophthalmologist to have your anti-VEGF injected, it takes a whole day, because you've got to get dilated, then you've got to get your injection in some in the West, in the US and all that, it's an office-based, but even in UK or here, we're still not doing an office-based procedure. So the whole day goes by, you have to take the patient to the theater, and then you have to take care of all the sterilizations. And then you have to look at other things also, like, the complications as more and more injections are being applied. You have to focus or keep this into account, that these patients can anytime have a lens touch, can also have vitreous cellular activity, or even can develop, God forbid, can go towards endophthalmitis also. So the more the injections, the more the risk of, developing side effects. So looking at that here, yeah, we start with the bevacizumab. If it's not working, then you can switch from one to another to see that whether the compliance, like the results of improvement in the central retinal thickness with the help of an OCT and clinical examination, is it working or not? You can switch from one to another, start with a bevacizumab, you can go to ranibizumab, and even aflibercept, and then you can even switch back. And if it doesn't work, then you can combine with the steroids and other things along with it. So the important thing is, and now that brolucizumab is coming, though it is at the moment FDA approved in 2018 or 2019 for just wet AMD. It is not available in Pakistan at the moment, and it's a bloody expensive drug. But considered that you can at least give 12 weeks of a break between your injection frequencies. You can have that break, but it comes with a cost, because there are certain, like, till now, about 14 patients have been identified who have had vascular occlusion, and as such, this drug is on a hold at the moment, and they're looking at the fact as why is it causing vascular occlusion, because the rest of the time, the first 3 ones are not doing so. So medications, anti-VEGFs are here to stay, and even now, anti-VEGFs have, even I read somewhere, it was just fascinating that anti-VEGF have even been injected suprachoroidal, it has gone backwards and present in the subretinal space and also, and in those places also. So anti-VEGFs for the time being are here to stay. You can switch from one to another, but it's always good to start with the very basic one, unless the patient has some systemic problems that you need to focus on first. Do not give an anti-VEGF without having a medical examination of your patient. And that goes for in children also. In case of ROP, if you've got to give it, I always strongly believe you've got to have a pediatric evaluation, a neurological examination, and a physical cardiological. Let's have a complete examination before you think of starting with your baseline anti-VEGF, because you will be surprised at what they might be, and I think it is not something that should be injected blindly. So switch from one to another, looking at the compliance, looking at the cost, and looking at the functional and anatomical correlations and improvements. So it can be done anyway.
Thank you, Professor Uma. In keeping with the anti-VEGF discussion, I'll direct my next question to Dr. Farah. So, Dr. Farah, we would like to know what is a post-injection pseudoendophthalmitis and how do you think it should be managed? Because it's one of very common complications, we come across it a lot. And so we would like to have your opinion regarding pseudoendophthalmitis, which is post-injection of anti-VEGF.
Thank you very much. Thank you very much. So, post of pseudoendophthalmitis, the pseudoendophthalmitis, I have mostly seen it in relation to the injection of intravitreal canacards. And it was very interesting because these patients, they presented with an anterior chamber that was just, it seemed like it was full of cells, and the vitreous was again full of, it was dense vitritis. I couldn't see the retina. And interestingly, the patient had no pain, no redness, just the complaint that I have lost my vision. So I think these cases have been reported worldwide in relation to intravitreal triamcinolone mostly. And these patients are mostly pain-free, and you do panic when you see them at first. And the patient is, of course, very much worried as well. But interestingly, these patients, in my experience, they just resolve very like in 2 to 3 weeks time with just like we just give topical antibiotics to be on the safe side. It's hardly ever needed to inject them with antibiotics. The topical antibiotics just do this job. We just have to counsel the patient that it is something that has been seen and has been reported with the use of intravitreal canacard and triamcinolone. So once the patient is properly counseled and you just keep them on a regular follow-up, these patients usually do resolve without any complication or residual problems in 2 to 3 weeks time. So I think that's very much it. If anybody would like to add on that in their experience.
No, I'm not adding on to that. I'm asking on to that. What about endophthalmitis post anti-VEGF?
So I think post anti-VEGF, I have never seen a pseudo endophthalmitis. It's actually
actual endophthalmitis. Yes, not a pseudo one. Obviously, it's not a pseudo one. So I would like to have the opinion of all these speakers here regarding endophthalmitis. God forbid you have one, but we do now and then. And sometimes we see it in the form of outbursts and outbreaks of a number of patients in one center where a single injection of Avastin was used for making a number of injections, and that resulted in causing endophthalmitis. So Dr. Rubina, Dr. Rahila, Dr. Huma, Dr. Nuzhat, and Dr. Farah, I would like all of you to put in a few words regarding anti-VEGF and that danger of endophthalmitis, and how do you prevent it and manage it? Anyone, all of you will answer it one by one. So just like you can think about it while we ask the youngest one. We will ask the youngest one first. She's stuck. Okay. Then we'll come to you, Rahila.
Okay, so in that case, I think that needs to be taken very seriously, and we should treat it like a proper endophthalmitis. The patient should be immediately admitted, and we should see the severity of the problem. If there is there is anterior chamber reaction and there is hypopion, we start with the topical antibiotics, as well as we take a tab, AC tab and a vitreous tab, and then also inject with the normal full antibiotic cover as well as the steroids. And I always see that what is the status of fundal glow and what is the vision of the patient. That is very important at presentation. So if it is a mild form of endophthalmitis, then usually my approach, and rather everybody's approach, is to wait and see that what is the response of the patient to that, to antibiotics and the intravitreals, as well as the posterior subtenon as well. So and the systemic antibiotics. And if the patient's vision starts deteriorating and the fundal glow, it disappears and the patient's vision is deteriorating, then I think it's the best time to go to vitrectomy rather than waiting for the patient to get worse. And an early vitrectomy is, I think, very good, has much better results in these cases rather than just waiting and letting that case get worse.
Thank you, Farah, for your opinion. And Dr. Rahila, would you
So,
like to say something?
yeah, I would say that the protocol that we have in the UK at the moment for our unit certainly is we tap and inject at presentation, regardless of what the vision is. And then at 48 hours review, if things are stable or getting better, then we'll start oral steroids at that time. And then we'll tap and inject again. And usually by day 5, we find that things are getting better. And this is particularly for the intravitreal injection ones, because we haven't put in an implant, an external foreign body that, the EVS was done for post-cataract. And we always tend to extrapolate the findings of the endophthalmitis vitrectomy study to every kind of endophthalmitis. But I think actually it doesn't apply. The aggressive organisms, the streps, for example, that will present within 24 hours, for example, will be very aggressive. So even early vitrectomy, you go into these hot eyes, it's not a great vitrectomy to do. And, your retina may already be necrotic and hemorrhagic by that stage. And sometimes you just cannot see what the posterior layer of the retina is. So all you're doing is debulking rather than anything else. So our practice at the moment is that we will tap and inject twice before we decide on vitrectomy.
Just for the benefit of the listeners, most of us will be interested, and it's easy to say tap inject. And can you elaborate on what to inject?
So I think our protocol is vancomycin and cefuroxime, or vancomycin amikacin, or vancomycin cefuroxime. I can't remember, because often this is done frontline in the A&E and then taken over by the trainees. So we've got it in our protocols. But vancomycin is definitely one of the antibiotics that we use. And the vitreous tap, sometimes they'll do an AC tap, but usually it's a good vitreous tap and we send the sample off, and there may or may not be growth. If it's worsening, it's usually because, we don't have coverage or you've got a resistant organism. So an early review of the microbiology results and changing your antibiotics. Often the poor vision and inflammation in the white stuff that you see is very, very inflammatory. So the minute you start oral steroids, high dose, tapering every 3 days from 60 milligrams, for example, really, really starts to make a difference. You can see fibrin clots retracting. The other thing I would just say while I'm here quickly about the pseudoendophthalmitis is that, when you get someone with a hypopyon, that's the worry, but the eye is not painful and it's not red. And one of the things that we tell our trainees in the accident and emergency department is keep the patient there for 6 hours, give them intensive topical steroids. If it's an infection, it will probably not get better or it'll get worse. If it's inflammatory, it will symptomatically get better. So that's sort of a one way that you can try and differentiate whether this is infectious or inflammatory or pseudo.
Thank you so much. Dr. Rubina, we would like to have your opinion regarding that as well. Please unmute yourself. Dr. Rubina, please unmute yourself.
So I just like to say a few words on prevention. So prevention is important. So aseptic technique and povidone, iodine 5%, conj wash, and obviously stat post-operative antibiotics after injections, and so that's standard, although some units don't use post-operative antibiotics for more than 3 days, but that's just a different debate. So going over to surgery, yes, I'm not too keen to operate on an endophthalmitis eye unless I'm sure that I'm going to do any benefit. When you have to go through the challenges of getting the view first, because often there are membranes, pupil doesn't dilate, there may be have to do a cataract or take out the lens, and then do a vitrectomy. Again, I would suggest that we do a very limited vitrectomy. The retina is necrotic, and therefore we don't want to put any traction on the retina, otherwise we'll end up with breaks, resulting in insertion of silicone oil, which will make matters worse. So yeah, it's and in terms of the antibiotics, it's we use vancomycin and ceftazidime, or vancomycin and amikacin, but because of the retinal toxicity, macular toxicity associated with aminoglycosides, the amikacin is not widely used. We routinely don't use dexamethasone unless we've ruled out fungal infection, or and then start with the, as Rahila said, oral oral steroids, very useful in this situation. So that's from me.
Professor Nuzhat, your experience regarding this?
My experience would be similar to actually Rahila and Rubina. Like, I would prefer to see whether we use vancomycin and ceftazidime in Bangladesh combination. I would tap and then send it to the for the microbiological analysis and give the injection and wait to see whether it's improving. Because if it is improving with subsequent injection, there's no need to go for surgery. As Rahila mentioned, and also Rubina mentioned, that this surgery, you are debulking really. You don't know the condition of the retina, and the outcomes are often very dismal. So, if you are getting, because these are because these are intravitreal injection we are talking about, not endophthalmitis after IOL implantation. So usually they tend to get better with tap and inject. If not I find it that they do respond after the first injection, Rahila can add, but suddenly after successive injection. So, and one thing I want to add as well, as Rubina said, the pre-injection protocol should be maintained to the T. But also, once you have an endophthalmitis case, often we see that it's not reported properly. The morbidity and the audit, medical audit, this should be done and it should be reported. And everyone that has been injected with this from the same vial should be monitored closely. And I think that is very important as well, that reporting a case of endophthalmitis and also fumigation of the OT, you have to find out where the lapses were. There should be a morbidity report and a meeting on it, and protocols need to be strictly adhered to after the case has improved even. So I think post endophthalmitis protocol is also very important to avoid future outbreaks.
Yes, you are very right. The source of the infection has to be found out, and this is very important, and it should be reported so that other questions can be saved and we can prevent further outbreaks of this kind. A last word on this from Professor Huma. Professor Huma, a last word. Please unmute yourself.
I think most of them has been fully covered, and I think the most important thing for me is, like, I consider the first 24 hours of this endophthalmitis very I take it very seriously, because if somebody is having the absence of retinal glow, or if there's a presence of hypopyon with element of pain, this is not something that will just go away with subconjunctival injections or with just an intravitreal. So I think the element of pain is one of the most important thing, and the amount of hypopyon as how much it is regressing. So for me, I think I would like to admit these patients, and you ask my fellows to keep a tight lid on it, look at the amount of the hypopyon, if it's increasing in size or it's decreasing in size, or if it's stable. If it's static, that you can just give an intravitreal injections of the antibiotics chosen. And then you can, if the size of the hypopyon is regressing, then you can give another one, later, with 24 or 48 hours, what you choose. But the thing is, if it's not, and if the hypopyon, even if it's in a 0.5 millimeter increasing in size, and the condition is like slightly worsening, or even let's select maybe considered as stable with no improvement in the retinal glow, then I think for us in this part, I think vitrectomy is the first choice. You just take your patient and have your vitrectomy, because early vitrectomy, there are lots of studies between, you know, when they've done early vitrectomy versus late vitrectomy. So early vitrectomy all usually have better results of, you know, clearing these microorganisms out and saving the retina, because later the retina becomes necrotic, like just Rahila and Rubina talked about, and this brooming and sweeping of these pearls that are lying on the retina becomes very difficult. And then it's always good, like there's a school of thought, but for me, I think I would like to inject silicone oil at the end, because I've seen that silicone oil not just acts as a tympanotic agent, preventing the spread of, you know, the remaining, if there's any microorganisms from one area to another, but it also has this antigenic, antigenic properties also. So it's if I'm going to do a vitrectomy on this, it has to be like a quicker one. Sometimes you can save in one injection, no improvement, I'll go in and have my vitrectomy done. If not, if there's an improvement, then yes, you can watch and see, and then you have to need to differentiate between a sterile endophthalmitis and a biogenic one. So I think a tight lid on the situation, and it's like a TikTok, it's an emergency, cannot be taken lightly. 24 to 48 hours are the vital times for you to for patients' vision to improve or deteriorate, or it's lost forever.
Thank you, Professor Uma, for your expert opinion regarding this. And we disorders, the diagnostics, the anti-Vegf, the steroids, the retinopathy of prematurity, and a good healthy discussions on the complications of VR surgeries of 27-gauge vitrectomies. I think we have had a very wholesome kind of a session today. I would like to especially thank my international speakers, Professor Nusrat Chaudhary from Bangladesh, Dr. Rahila Zakir from UK, and Dr. Rubina Rahman from UK as well, from taking time out from their very busy schedules to be with us and to inform us regarding their expert opinions for various VR disorders. We are very lucky to have had a very good session, in the sense that with online webinars, technical issues are very common. So I think there were very few of those today. Apart from the good discussions, lack of technical instabilities, and a good audience. And we had kept some time for the audience questions at a later date, but during these sessions, as the questions came up, we also discussed those. Thank you very much to Professor Huma Kiani Saikul, who is also the General Secretary of WIOP, Women in Ophthalmology here at Pakistan. And I would especially like to thank Professor Seema Qayyum, who is the President of the Women in Ophthalmology Pakistan, who has been with us in this session throughout. Thank you, Dr. Farah, Dr. Tahmina, and our audience for being with us today. This is Professor Sufia Farooq signing out from the third session of Women in Ophthalmology Pakistan. Thank you, everyone, for joining us.
Sufia, let me thank you, because for conducting, and congratulate you for conducting such a wonderful session, and a hands up applause to you, because taking switching from medical retina to surgical retina and then coming back, it's not an easy task with such well constructed questions, and keeping an time. It's the most important is time management, the way you conducted it and the way you took from exactly between 5 to 7 p.m., keeping everything in mind, giving an opportunity to everybody to speak like as they wanted to and express. I think you've done a wonderful job, and congratulations.
Thank you so much, Professor Uma. Thank you, everyone. I had a very cooperative group of speakers today who went along with as I went along. So thank you, everyone. Thank you, our audience. Thank you, our team, Sante, for providing the technical support for this session.
Yes, thank you.
And we will now sign off. Goodbye, everyone.
Thank you.
Bye.
Bye.
Have a nice weekend.
Bye.
Bye.